It's a great pleasure for me to introduce my teacher and good friend, Dr. Halperin. Dr. Halperin has a bachelor's degree in physics with highest distinction from the Purdue University back in '71. Then he receives the master's degree in physics at the University of California in Berkeley in '72. Following that, he went to medical school and he received his MD from the Louisiana State University in New Orleans in 1977, and he was a fellow in cardiology at the Johns Hopkins University in Baltimore between 1981 and 1984. He's a member of the Phi Beta Kappa and is established investigator and fellow of the American Heart Association and the McClure Fellow of the Johns Hopkins University Applied Physics Laboratory. Dr. Henry Halperin is currently a professor of medicine, a professor of radiology, and a professor of biomedical engineering at the Johns Hopkins Medical Institute, and is a clinical electrophysiologist at the Johns Hopkins Hospital in the Division of Cardiology. He is the co-director of Cardiovascular Imaging Center of Excellence. He serves on the editorial board of the journals Resuscitation and is a past chair of the National American Heart Association Advanced Cardiovascular Life Support Day, CLS, subcommittees and a past member of the Emergency Cardiac Care Committees. He is also an editor of the textbook on resuscitation. His current research interests include cardiopulmonary resuscitation, electrophysiology, magnetic resonance imaging, MRI implanted device interaction, and advanced image-guided interventions. 6 of his past students have received Young Investigator Awards from the American Heart Association and Heart Rhythm Societies. And he has an ongoing support from the National Institute of Health for his research programs. He has over 100 peer-reviewed publications and over 20 patents issued. And we are delighted to have him here, and he will give a talk about MR-guided intervention. Thank you very much.
Thank you, Ariel, for that very nice introduction, and I'd like to thank Dr. Blezer and Dr. Bayar for inviting me here, and I'd especially like to thank everybody for showing up so early to listen to this talk. So since I'm an electrophysiologist, a lot of this will be about electrophysiology, but there are some slides about some other aspects of MR-guided intervention. So just, this is required by Johns Hopkins. So atrial fibrillation and ventricular tachycardia are the most common arrhythmias in humans. Atrial fibrillation, basically, as probably most people know, is basically chaotic electrical activity of the upper part of the heart. It affects millions of patients in the United States. There's 400,000 new cases per year. The symptoms are significant, include palpitations, fatigue, shortness of breath, and lightheadedness. And they cause lots of strokes per year in the United States and also around the world. And antiarrhythmic drugs are often ineffective and sometimes dangerous. Michel Morawski, who invented the implantable defibrillator and was a native Israeli, basically said that antiarrhythmic drugs were toxic chemicals with a few useful side effects. So ventricular tachycardia is another major arrhythmia. It affects millions of patients in the United States and similar numbers throughout the world. It causes syncope and sudden death, and it does require an implantable defibrillator and often antiarrhythmic drugs. So ablation can cure many arrhythmias. With ablation, you apply some form of energy to select parts of the heart and destroy antiarrhythmic or arrhythmic circuits. So with atrial fibrillation is due to arrhythmogenic foci, generally in the pulmonary veins. We see a schematic of the left atrium, the pulmonary veins. Initially, people tried to put catheters into the pulmonary veins and actually find those foci and ablate them, but it's actually very difficult to find the foci, and often the pulmonary veins would be damaged by the ablation. So people found that, in fact, it didn't matter if the pulmonary vein fired very rapidly to produce atrial fibrillation if, in fact, you ablated around the pulmonary veins to kind of build a dam around there and isolate the pulmonary vein. So currently, the treatment of choice for atrial fibrillation is electrically isolation of the pulmonary veins. In most good labs, including our own, the isolation rate's 95 to 100%. Everybody can isolate pulmonary veins. But the recurrence rate, even in the best labs, is generally 20 to 30 or even higher than that percentage. So even though you can isolate the pulmonary veins, something happens to allow the arrhythmia to recur. And then with ventricular tachycardia, there's actually scar in the left ventricle and sometimes in the right ventricle. This is shown schematically where the gray is normal myocardium and the red is scar. Due to ischemic heart disease or even non-ischemic heart disease, scar forms, and a reentrant circuit can occur through and around this scar. So the goal of ablation then is to break the circuit by ablating the normal tissue on the edges of the scar or the normal tissue that's inside the scar. The current success rate for ventricular tachycardia ablation, though, is only about 60%, and these procedures are often prolonged. They can be anywhere from 4 to 6 or even longer hours. So the state of the art in ablating these kinds of arrhythmias now is 3D image integration. So I'll just run you quickly through how this works, and it's of great significance here because a major part of this was developed here at the Technion in Israel. So with 3D image integration, the first part is 3D imaging and segmentation. So here we see an MR or a CT image that's been made in 3 dimensions, reconstruction, and then the various sections of the heart, the left ventricle, the right ventricle, the atria, the aorta, the pulmonary arteries, are marked manually. Computers are very difficult time in finding these things on their own. So then once the various structures are marked, then a computer algorithm can be used to find the extent of those structures. And this is this procedure called segmentation. Sometimes the computer gets it right, sometimes it doesn't, but an operator can actually fix it up. Then, if you're doing an atrial fibrillation ablation, you would isolate the left atrium. If you're doing a ventricular tachycardia ablation, you would isolate the left ventricle. So there's chamber isolation. Then the next part of this system is the navigation system. And this, the one that's used most often, there's a number of different navigation systems, but the Cardo XP, they call it now, it's sold by Johnson & Johnson. It was actually developed at the Technion by Shlomo Ben-Haim, Lior Gepstein, and others. Is shown here. There's basically a section that goes under the patient, and this consists of a number of coils. These coils actually produce a number of different magnetic fields, and then the catheter tip has a sensor in it. The sensor picks up these magnetic fields, and depending on the strength and the phase of the magnetic field, it can actually determine where the catheter tip is to within a millimeter of accuracy. It's really been a major advance. Then what one does is one puts the catheter in the body and puts it in the pulmonary veins. Here you call the left superior, right superior, and then the inferior pulmonary veins. And then what you do, you try your best to mark the junction of the pulmonary vein, say, with the left atrium, and you have 4 marks. Then what you do is you mark similar positions on the 3-dimensional image. So you mark where you think the left superior pulmonary vein, left inferior, and right superior pulmonary veins are. And then the computer actually aligns these two. So it aligns the space of the Cardo system with the 3-dimensional image. And then what you do is you actually go around inside the left atrium in this case and actually touch different parts of the atrium, and then this produces different points, and then you can do this 50 times or 100 times. It actually sounds tedious, but it actually goes very quickly. And then the computer does a registration algorithm which minimizes the distance between the two systems, and then that produces then the image integration. Then what you do is then you can use the system in order to do 3-dimensional image-guided integration. So here's an example of an atrial fibrillation ablation being done in our laboratory. So we see the 3-dimensional image in 2 different views, and then the catheter tip you see shown here. And then what you do, you're trying to go around the pulmonary veins to isolate them from the left atrium. And then you drag the catheter around while the ablation energy is being applied. And then every 5 or 10 seconds, the operator assistant actually puts a dot where the ablation should have happened. And then this procedure is repeated until there's no electrical connection between the pulmonary veins and the left atrium. And this can take anywhere from 30 minutes to 2 or 3 or 4 hours. A similar procedure is done with ventricular tachycardia. In this case, there's a scar typically in the left ventricle. Here's the three-dimensional left ventricular view here. And what you're typically looking for here is the earliest activation. That's where the critical slow pathway would be for ventricular tachycardia. It usually requires slow conduction in order to sustain the circuit. So what we see here is the early part is shown in red, and then underneath we see this reddish, yellowish color. This is the earliest part of the circuit, so that's really where the circuit was. And then you apply a number of ablations there until the ventricular tachycardia is abolished. If there's a number of different kinds of ventricular tachycardia, you might actually have to search to different parts of the left ventricle, but this CARDO system is actually very good at allowing you to keep a catalog of where the catheter has been and where you perceive the ablations to have been. And the clinical outcomes using this system have actually been improved. This is from the Kistler-Schilling group, which actually shows patients who were in atrial fibrillation and then had sinus rhythm maintained at 6 months. And this is the first half of a study group, the second half of a study group. So they got more experience here and then the total experience here. So this is the computed tomography with this electroanatomic mapping or this three-dimensional image integration. They're claiming an 85% success rate, which is actually quite good. Most people usually get 70 to 80% at that point. But anyway, that's a much better success rate than just three-dimensional mapping without the image integration. And there's really not much of a learning curve here. So it really does help. This three-dimensional image integration helps with the clinical outcomes in terms of freedom from atrial fibrillation in this study population. But there are, unfortunately, limitations to this system. The main limitation is what we call underestimation of gaps. So this is a three-dimensional picture of a left atrium with the right superior pulmonary vein, and we can see that a very experienced operator actually moved the catheter around this pulmonary vein, and actually it appears that there's a very complete line of ablation that has been placed around the pulmonary vein. But as I mentioned, this only tells you where you think the catheter has been and where you think the ablation is done. But at autopsy in this animal, you can see that there's actually a number of gaps that are present, which you really can't see on these pre-acquired images. And unfortunately, recurrences of the arrhythmia are related to gaps. There's electrical reconnection. Something transiently occurs that you get isolation, and then with the gaps, conduction can be recurs, and you can actually get arrhythmias. And then there's other limitations. The heart size and position can change from the pre-acquired images. There's limited visualization of the moving anatomy and device tissue contact, and there can be registration errors. But all that said, this has been an amazing advance in the state of the art of doing ablations in electrophysiology, and these same types of systems are used in a number of kinds of interventions in order to improve anatomical accuracy. But if one could then see the tissue in real time and actually see the results of the ablation in the tissue, rather than just seeing where the catheter was, that would be a substantial advance. And that's really what we've been working on, and the bulk of the rest of the talk will be related to real-time MR-guided procedures, which we think is the future, and we actually think it's the fairly near future. So then the rationale for using real-time MRI is that there's accurate anatomy. This is a real left atrium image from a patient showing the different pulmonary veins and actually showing the very close anatomic proximity of the left atrial appendage. You can visualize different kinds of soft tissue. You can actually see ablated lesions, which I'll show you a number of slides on. You can do real-time three-dimensional imaging. There's no ionizing radiation, so you don't have to wear lead. And interestingly, it's a similar cost as a high-quality biplane X-ray system. So the first part of this was catheter development, because the issue would be you wouldn't think that you could stick wires and other metal inside an MRI scanner without having major problems. But it turns out that these problems can all be mitigated. This is a first-generation catheter that we had made from Irvine Biomedical. It's actually a standard ablation catheter. You move this actuator back and forth, and it actually deflects the tip. And so if you take this catheter, remove all of the magnetic materials from it, which is what we had done, and then put it in an MRI scanner, if you have very high-powered MR scans, what in fact will happen is that the tip of the catheter will heat up. This is just an index that radiologists like to use to indicate how much power is being absorbed around the tip. And it turns out that this amplification factor of 500 would translate into the rise in temperature of the tip of about 30 degrees centigrade. Okay, that would raise that temperature from 37 degrees to 67 degrees, and it only takes 50 degrees in order to ablate tissue. So this would cause ablation in undesired places. So this would be bad. But in fact, we did get IRB approval as well as FDA approval in order to use these in patients if we used very low-powered scans. And this does limit the imaging, but it would be useful for looking at the feasibility of this approach. So we've done a few patients, which I'll show you a little later in the talk. But in order to use all of the imaging capabilities of MRI, you have to be able to use full-power MRI scans. So we developed an improved MRI-compatible catheter. And this could be used for electrophysiology. It could be used for other types of ablation as well. So what we did is we just put some radio frequency rejecting elements in the tip of the catheter. And then with this system, you see that this SAR amplification factor goes way down at the tip. And in fact, this corresponds simply to a temperature rise of 1 or 2 degrees centigrade, which is actually well within the limits that the FDA would allow. And these are some homemade catheters that we've done. We're actually getting some commercially made so we can use them in patients, and they're actually very close to being done. This just shows you an example of then catheter manipulation inside an MRI scanner. This is a single plane. This is actually an injection catheter. We have a stem cell injection project going on. And the things of note is you can see the tissue. This is the left ventricle. This is actually a pig, but you see the septum here. You see the lateral wall of the left ventricle here. And you see that some stuff was injected right there, and you can actually see exactly in the tissue where it was injected. So this just really starts to show you some of the power of MR-guided interventions, because you can actually see what you've done. You can actually see, is the injectate really where you think it is? Is the lesion really where you think it is? But imaging has to be improved over those just two-dimensional planes. So Siemens and Mike Gutman have developed this, what they call this dynamic imaging plane. They call it this interactive front end. And they have 3 real-time orthogonal planes. And some people find these 3 real-time planes helpful. I actually find it a little confusing. My mind doesn't work in 3 dimensions quite that way. So, and I think most electrophysiologists like 3-dimensional pictures. So what we've been working on is actually having a dynamic heart picture where we actually have a pre-acquired MR image of the heart in 3 dimensions where you actually see all the dynamics, and then we actually have 1 or more real-time imaging planes registered to this so that this 2-dimensional plane updates the 3-dimensional image in real time so that you can have current real-time information as you go along through the procedure. And then to take this one step farther, this is hot off the press, so I apologize for the graininess of the film. This was actually just done last week. But here we see, this is a real MR-guided procedure right here. And this is actually Yoav Dori from the Technion, who's doing a fellowship at Johns Hopkins, and we're actually manipulating this catheter in a pig. He's actually doing a right heart cath. He's a pediatric cardiologist. But here what we see are multiple imaging planes with the 3-dimensional image. And you can see this is the left ventricle here, this is the septum, the lateral wall, and these white marks here are actually markers, locators on the tip of the catheter that allows you to track the catheter through the heart. It looks better on the small screen, but this just gives you an idea of really where this is headed. One really exciting aspect of this is the ability of the MR scanner to actually deflect the tip of the catheter. So this then allows automatic control of the catheter, because what we see here is this catheter is moving up a phantom. There's some coils in here, and just by adjusting the current going through the coils, the tip of the catheter is actually deflected into the side branch here. So that way, this would allow very, very accurate manipulation of the catheter inside the MRI scanner to be done automatically. So there could be pre-programmed sequences as to where you wanted the catheter to go. So whether you're working in the brain or the heart or even in the abdomen, this magnetic tip deflection could allow very accurate and very reproducible movement of the catheter. So then electrophysiologists have to be able to make electrical recordings during imaging. And this just shows you that, in fact, even when there's 8 or 10 kilowatts of radio frequency energy that's being applied to the body in order to get MR imaging, you can actually measure millivolt signals in the heart. This is a pig heart where this is the left ventricle, this is the right ventricle. There's an MR-compatible catheter here, which you barely see, and then these are real-time electrograms done during this imaging. And with electrophysiologists, it's important to have multiple electrical measurements in different parts of the heart, again, during imaging. So noise is potentially an issue as the MR scanner is applying its imaging power in order to make the images. So here we see a catheter that was placed in the high right atrium. This is the atrial signal. This is in the right ventricle. This is a ventricular signal. And this is at the tricuspid valve. So you see the atrial, actually a signal from the bundle of His, as well as the ventricular signal here. This is outside the scanner. These traces are very clean. The signal-to-noise ratios are quite good. You see these nice spikes and then a relatively flat baseline. Inside the scanner during imaging, it's important to have noise-free or at least low-noise signals. So in the right atrial signal, we see this extra noise that occurs. This is actually from the gradient fields, which are needed in order to produce the images. But this particular tracing doesn't have any filtering in order to get rid of this gradient noise. These other channels have increasing levels of filtering, and the right ventricular signal actually has our best filters for getting rid of all the extra noise produced by the MRI scanner. And then what you can see is that, in fact, there's just as good a signals inside the scanner during imaging as there is outside the scanner, indicating that, in fact, we can get diagnostic quality electrical signals from multiple catheters during high-power imaging. So then what's another very exciting aspect of this is the ability to visualize scar, because ventricular tachycardia is intimately related to scars that are fairly irregular. So one of our fellows had this 10-week swine left anterior descending coronary artery occlusion model of ventricular tachycardia. This particular model is also used in our stem cell injection project. So it turns out that after 10 weeks, almost all of these swine are inducible with ventricular tachycardia. So what Hiroshi did was did very detailed MR imaging of these animals, and what you see typically is here's a cross-section, post-mortem MR image, where you see the normal tissue in gray, and then you see the part that's been infarcted, which is replaced by scar in white. And then this is a cross-section, and then we did these very detailed three-dimensional reconstructions. Here's an anterior and a posterior view, and you see that the scar is then shown in this kind of gray-black area here. And what's interesting about this is that what it shows is, in fact, there's islands of infarct within the viable myocardium and also islands of viable myocardium within the infarct. So then this is important for how ventricular tachycardia occurs in this particular model. Then the next part was to put a multi-electrode array over the outside of the heart. This is basically just a sock that goes on the outside of the heart that has multiple electrodes, each shown by these dots. And then you can actually do electrical stimulation in order to induce these ventricular tachycardias. And depending on how you stimulate, a number of different ventricular tachycardias can be induced in each animal. You can see that there's a circuit from these different colors from early to late, from A to B to C, all the way around to I. These are just different timings. And this just shows the timing of the wavefront going from A to B to C, all the way to I, just showing this kind of circular motion. And then the kicker in this is that the scar was then registered to this. So the scar is here, and then we see this ventricular tachycardia circuit, which is shown by this yellow line going around. And what's important about this is that this scar over here is shown in more detail here and here. And what we see is that the part of the ventricular tachycardia that goes through the scar, and there's a delay in electrical propagation through the scar, that delay is a critical part of the ventricular tachycardia circuit. If you don't have the delay, then you won't get these reentrant circuits. But what we see, what allows that to happen, is we see this gray material inside the white scar. So that gray material is normal myocardium inside the scar, and that then is the substrate for the ventricular tachycardia. And then the obvious thing would be, well, gee, just do imaging, find that stuff, ablate it, and you're done. And that's really, it sounds really easy, but that's really would be a major breakthrough if we could actually do that. And then the other really exciting thing about this is that this scar can actually be fairly complex. This is actually the same scar. We're looking at the heart in the front and then the back, and the same scar is very complicated. It has all these little fingers and everything, and it turns out in the same animal, a different ventricular tachycardia circuit went through a different part of the scar. And it's very common for a patient or an animal to have multiple different kinds of ventricular tachycardia. It might look differently. And it turns out it can be very difficult to ablate those ventricular tachycardias. And this shows that, in fact, the same scar can give rise to a number of different morphologies of the ventricular tachycardia, and that all one potentially has to do is find these irregularities, find this normal tissue in the scar, ablate all that, and get rid of it. So that's really one of the powers of this potential thing. So then kind of the holy grail here, we think, is lesion visualization. Because the major weakness of current technologies is the inability to know, in fact, if you put lesions where you think they should go. And the idea is that if you can put lesions exactly where they need to be, then you'll be successful. So this shows imaging of ablated tissue in the atrium, which would be important for an atrial fibrillation ablation. So we put a number of lesions in the left atrium, and this shows on MRI as these white areas. And then we did histopathology on these. This is Mason's trichrome stain, and the blue areas are the dead tissue, the red areas are the live tissue, and we see that this lesion here corresponds to this lesion here, and then this lesion here corresponds to this lesion here, showing that MRI can, in fact, visualize the ablated tissue, and it corresponds very accurately to the real lesions that were there. But can this occur quick enough inside an MRI scanner to be used for real-time titration of the lesions? And the answer to that is yes. This fairly complicated slide, which I'll lead you through, shows the signal intensity, which is encoded from blue to red. So the very white area would actually show up as this red area. And so the signal intensity across position on the animal and then across time shown here. So before the ablation starts, the signal intensity is very low. And then within a minute of applying ablation, the signal intensity actually goes up dramatically, allowing the lesion to be detected, and then it goes up a little bit after that. So what this shows is that within a minute or less, because the minute was actually the minimum time increment we had available in these particular situations, within a minute you can visualize these lesions. And that's plenty fast enough in order to be able to use this for real-time monitoring of the ablations. And then the next part of this is gadolinium lesion enhancement. It turns out gadolinium has been used for many years in order to enhance the visualization of scars as well as lesions done by ablation. So here we've applied lesions in this particular model, and we injected the gadolinium. Initially, the gadolinium does not diffuse into the lesion and shows up as a black area in these images, and the rest of the right ventricle is shown as these white areas. And then within about 30 to 60 minutes, the gadolinium washes out of the myocardium and into the lesion, showing this enormous signal-noise ratio difference, enormous contrast, showing these lesions actually quite well. And they actually correspond very well to the gross pathology that's shown on this particular specimen. And then we can do three-dimensional imaging of this to actually see these lesions very nicely. So that, in fact, if you wanted to use this to guide your procedure, you see these lesions very nicely, and you can see that it would be probably fairly straightforward to navigate a catheter in between these to fill in this gap. And I'll show you the importance of that in just a minute. The accuracy of the lesion size estimates is very good. This is the lesion size by MRI and the pathology lesion size. And for the contrast void, as well as for the delayed enhancement, the accuracy is quite good, showing that MR imaging can give you a very accurate estimate of these lesion sizes. And then the really important part of this is detection of gaps in the linear lesions, because I showed you earlier that one of the limitations of current technologies is you really can't see these gaps, and you actually have to use fairly tedious electrophysiologic means in order to find the gaps. And in fact, gaps can occur after some healing of the myocardium. And then the other notion here is that by visualizing gaps and visualizing filling in the gaps, you actually might be able to predict when conduction block has occurred. The analogy here is if you build a dam across a river, where the river is the arrhythmia, if there's holes in the dam, then your arrhythmia is going to continue. And you want to be able to very accurately find those holes and fill them in. And that's exactly what we're trying to do with these ablations. So here we see a study that we've done fairly recently where a lesion was placed under MRI guidance. This is real data. This is just a still where we see the left ventricular wall here, three-dimensional rendition. This is a catheter that's been placed retrograde through the aorta onto the anterior wall of the heart, and then a lesion was done. So this is just colorized lesion in order to just show a better view of it. Then this fairly complicated slide actually just shows a number of different views of the imaging plane where we see that here's, we're looking at a lateral view where we see the anterior wall, the posterior wall. This is the first lesion that you saw in the previous slide. And then this is a second lesion that was placed where there's maybe 2 or 3 centimeters of gap in between those two lesions. And then what we did is we came back later and actually did ablations along the line between these lesions and actually filled it in. So then this purple area here is actually new lesions that were placed in order to fill in this gap. So we see this is actually kind of the first time that we actually demonstrated explicitly that we could actually make a line without gaps to fill in between two lesions. This yellow dot here is actually a marker on the catheter that we're actually using to track the catheter. And then the importance of that is that if imaging parameters alone can be used to tell where there's gaps and to tell whether the line's complete, that could predict when you have conduction block. And conduction block is really the critical thing that you're after in an electrophysiology procedure. So this then shows the relationship that shows, in fact, that imaging can predict conduction block. It's kind of an imaging parameter is being used to predict an electrical parameter, which would really be the first time this has been shown. So what we see here is a lesion on the right ventricular wall and another lesion with a fairly large gap in between those two. We paced on one side, and then we sensed on the other side. So then electrically, what you see this artifact from the pacemaker, and then the sensing on the other side, the sharp deflection here occurs when the wavefront goes past the sensing catheter. And we see there's about a 20 millisecond delay between pacing and sensing, which is about the normal time it would take for the impulse to travel from one side of the gap to the other side of the gap. Then what we did is we navigated a catheter to the space in between these two lesions, filled in the gap, and then paced and sensed again. And then in this case, the sensing occurs about 40 milliseconds after it did before, indicating that instead of the impulse going through the gap, it's actually going around, showing that in fact conduction block has occurred around this gap. And then this has led to some clinical studies because we've been fairly successful in the animal studies, and we actually did get FDA approval to do some clinical studies. So with IRB and FDA approval, we've done a few patients. This is the MRI scanner. This just shows the preparation of the patient for the procedure. And then this is the first ever MR-guided placement of a catheter in a patient. This is actually me pushing this catheter. And I apologize for moving it so slowly, but I didn't want to have any problems occur in this first ever patient. But in any event, what you see is this catheter coming up the inferior vena cava into the right atrium. This is the right atrium. This is the right ventricle. This is the tricuspid valve. These are the electrograms, the right atrial spikes, as it's touching the right atrium as we're moving it into position to actually hit in the tricuspid valve area. So then, in order to really expedite the ablations, we're looking at arrhythmogenesis modeling because we think that not only can we visualize scar and visualize normal myocardium in the scar, which is the substrate for ventricular tachycardia, but we think we might actually be able to prospectively predict where these circuits are and then use those predictions in order to help guide the ablation as well. So these arrhythmogenesis models are done in collaboration with Natalia Trinova at Hopkins. We use realistic 3D finite element model with normal tissue and scar, detailed ionic channel kinetic representations. This was developed a lot by Yoram Rudy, formerly from the Technion. And then there's a tightly coupled simulation experimental approach. And then on this slide, we actually see kind of the steps through the model. First, we do these fairly detailed imaging of the heart. We see the left ventricle and the right ventricle. Some diffusion tensor imaging is done. This actually allows imaging of the fiber directions, which we see here. Then the scar and the normal myocardium is segmented. This would have been a scar area and a border zone inside this more normal tissue. And then the model is actually used based on this finite element modeling to predict where it thinks the arrhythmia circuit will be. And here we see the scar, and here we see the circuit going in this particular projection. And then what's fascinating is that the computational model, with its prediction of where the ventricular tachycardia circuit would be, is surprisingly similar to what we see actually in our pig models, where we actually see a similar figure of 8 ventricular tachycardia pathway. Again, this is relatively new data. We haven't done a lot of formal validation studies, but it looks very exciting. The idea here is that if you could prospectively predict where these ventricular tachycardia circuits would be based on a particular patient's anatomy, that would help guide you to exactly where you want to do your ablation. So rather than a 3 or 4 hour ablation, you might be able to do this in half an hour. With much less morbidity than what you would get normally. So then the summary for this MR-guided electrophysiology is MR images can be obtained in real time during electrogram acquisition and during ablation. MRI can be used to guide catheter navigation. The catheter tip can be deflected using magnetic fields. Ablated tissue and true anatomy can be visualized and localized, making three-dimensional maps feasible. Gaps in lines of ablation can be found and filled in, and imaging can be used to predict conduction block. Now, there are some limitations. This would require a paradigm shift, but if this is going to actually allow much better procedures to occur, then it would probably be worth it. An MRI scanner is required. The components must be MRI compatible, but this is relatively easy to do. There's acoustic noise from the MRI scanner, but newer scanners are reducing this. Image processing requires further development, and we're probably maybe 1 to 3 years from MR-guided clinical ablations. But the conclusions for MR-guided electrophysiology is real-time MR-guided studies are feasible, real-time imaging, anatomy, magnetic navigation, visualization of ablated lesions may improve the safety and efficacy of ablations and reduce procedure times. So then, it's not only electrophysiology that could benefit from MR guidance. This actually shows aortic valve placement done by Elliott McVeigh and others at the NIH. And what we see here in an animal model is a trocar was placed into the apex of the left ventricle. We see very nicely the septum and the lateral wall of the left ventricle. And then this aortic device is actually being placed through this trocar, and then this is being advanced into the aortic valve position. And then you'll see in a few seconds that this is being deployed like a stent in the aortic valve. So, with improving technology, this thing could be probably made much smaller, and maybe with just a little trocar into the left ventricle through the chest wall, you might actually be able to place an aortic valve, which would be kind of neat. And then other people at the NIH have been used this to dilate coarctations of the aorta. This is an animal model where you can see that the device was placed up into the coarc, and then this balloon is inflated, and you see very nicely the anatomical relationships between the aorta and all of its surrounding structures. And then there's many other organ systems could use this, but we have limited time. So then what about implanted devices? It turns out that many of the patients who come to electrophysiologists have or will get implanted devices, and in the past, the presence of an implanted device has been a contraindication to doing MR images. So if this was still the case, this would pretty much limit what we could do with real-time MRI. So we embarked on a study to look at the interactions between MRI and devices, because we felt that this was a critical aspect of doing this particular technology. So let me start out with a few cases, since this is a clinical conference. Here's a 59-year-old woman with paraplegia. A pacemaker was placed for bradycardia. She had acute onset of lower extremity weakness, paresthesias, and urinary retention, and no pathologic findings were detailed in a CT scan, which is shown here. This is told by my radiology friends that this is absolutely normal CT. An MRI was recommended, but she couldn't get it where she was because she had a pacemaker. And then another case, a 30-year-old woman with seizures. A pacemaker was placed for bradycardia in 1998 after an automobile accident. She subsequently developed intractable seizures. She's married and desired to have children, but was advised against it because of these intractable seizures. CT of the brain showed an ill-defined density, inadequate for diagnosis or staging of therapy, and an MRI was recommended. Again, she couldn't get it where she was because of the contraindication. So background, MRI can provide information not readily obtained from other imaging modalities. It's estimated that at least half of all patients with implanted devices could benefit from an MRI, but it's currently contraindicated in most centers because of theoretical effects of torque, heating, inhibition, rapid pacing, and there have been 13 deaths reported of patients who have had MRI scans who've had a device, but these have all been what we call inadvertent scans. None of these patients died during monitoring. So here's a graph showing number of ICDs and MRIs over time. They're both going up dramatically. Early devices before 1990 were clearly not MRI safe. There's a number of studies showed that some were triggered at the gradient field, so these would have paced at 200 or 300 per minute. In this particular study at 0.5 Tesla, they were inhibited, pulse at 800 per minute. In this particular study in 1987, notice these were all in the 80s. The pacemakers were triggered or inhibited. So that's why there's the problem. It turns out that if MRI scanners were only invented today, this would never have been an issue. So then there's this warning, no pacemakers, no metallic implants. Modern systems have evolved. Should our thinking evolve? So these are older devices, newer devices. They have less ferromagnetic material. They're smaller, have improved electromagnetic interference protection. At 0.5 Tesla, 51 patients had no problems. At 1.5 Tesla, 107 leads, 61 pacemaker generators. A number of studies were done. No adverse events occurred. No studies were interruptions. But they had a number of lead changes, and these were in older devices. And then some are more recently, safe imaging 1.5 Tesla, 115 exams, no pacer-dependent patients. There was no pacer dysfunction, arrhythmias, or reprogramming. There's a small increase in pacer capture threshold, and 2 patients did have a rise in troponin. So should we do MRIs in pacemaker patients? The MRI device interactions are not fully characterized, but we're getting there. Continued caution is still warranted. These are some very well-known people in the field, and we agree with that. But the risk-benefit ratio is reasonable when there's a strong clinical indication for MRI. So we do these things routinely now. And what about defibrillators? This is some work published by Ariel Roquin when he was doing his interventional fellowship at Hopkins, looking at modern pacemaker and implantable defibrillator systems. So defibrillators are more problematic because they're larger than pacemakers, they have longer leads than pacemakers, they have a ferromagnetic transformer, which is used for generating the high voltage for the shock, and this could increase image distortion, and maybe there will be forces or torques acting on the generator that may be dangerous. And they also have power control circuitry, which have ferromagnetic materials in them. So Ariel did this very nice study, in vitro and in vivo, where we looked at heating, force, function, and then image distortion. So we really broke these devices into 2 categories. The devices from Medtronic, St. Jude, and Guidant were studied. Those are the 3 major manufacturers in the US. This line here, to the left of the line are devices that were approved before 2000. To the right of the line were devices that were approved after 2000. We consider this the modern era, and we consider this the ancient era. So we looked at temperature, which was Temperature rises were less than 1 degree centigrade. Torques were very small. Forces were very small. This is a fairly complicated slide, but I guess time's getting limited. So anyway, it turns out we see in yellow things before 2000 where there were some problems. We actually wound up destroying a bunch of these mini devices. But anything after 2000, there were no problems with parameters or memory or interrogation. And then Ariel did this study where we implanted devices at time 0, interrogated them every week, did a lot of MR imaging, and then interrogated them every week after that, and then sacrificed them at 2 months. And the pacing thresholds actually increased at all pulse widths up to 4 weeks. Then we did MR imaging right here for 3 hours at very high power. And then the pacing thresholds actually decreased. So the message here, you could interpret it as MRI should be done on everybody to reduce their threshold. Obviously, this was just a happy coincidence because this is kind of the normal evolution of the capture threshold, but at least the MRI did not seem to hurt it. And then pathology, the important one is actually shown here where there's Mason's trichrome strain. This is where the lead was. There's very little blue. In the blue, there's a little bit here, there's a little bit here. So there was no evidence of damage to the tissue. And then the images, you can actually see the lead here, you can see the generator here, but you actually see the heart quite nicely. So you can actually get diagnostic quality images. There is some noise in the ECG circuitry of the device, which would be interpreted as ventricular fibrillation. So you have to actually turn the device off, but that's actually not a problem. So then we have this Johns Hopkins Hospital MR device imaging protocol. Because no adverse effects with modern devices with the device programmed inhibited or fixed rate and the patient monitored have occurred. So the protocol, the generator was previously tested to be MRI safe. It's interrogated pre-MRI. It's programmed to inhibited or fixed rate. There's monitoring during the scan. The device is interrogated post-MRI, and then it's reprogrammed to the pre-MRI parameters. And this was published a couple of years ago. Ariel was a part of this study. And we did 68 MR examinations. We performed 55 patients. Roughly half and half had pacemaker ICD, and a number had biventricular pacing systems, and a number were pacer dependent as well. No symptoms consistent with any problems, no inappropriate inhibition of pacing, no unexpected or rapid activation of pacing. And the device parameters, P waves, R waves, captures, nothing really changed acutely or at 3 months follow-up. And the image quality was actually quite good. Diagnostic questions were answered in all non-thoracic and 92% of thoracic sequences. And the clinical findings were significant: vascular abnormalities, malignancies, cardiac viability. And the images were actually quite good. We see this is a corrected transposition in a young adult. And here we see the right atrium with the lead and the coronary sinus. This patient, they wanted to see if the coronary sinus was patent. We actually see very nicely the coronary sinus. And it even identified a lateral branch, which was the target for this biventricular lead placement. So then the clinical study update, we've now done 234 MRI examinations in 185 patients, roughly half and half with pacemakers and defibrillators. The monitoring and programming has been done by a device nurse since it's now a routine. No adverse events, no significant changes in pacing parameters. And diagnostic questions were answered in 95% of these patients. So enormous clinical utility. And this is compared with only 17% of 45 patients with conventional imaging had diagnostic information that was useful from those alternative scans. So you see that MRI really is much better, and in these patients can make the difference between diagnosis or not. And the data is adequate for approval of research studies. And then very quickly, the 30-year-old woman with seizures, the MRI showed well-defined mass with surgically removed and benign, seizures resolved. She did deliver a normal child a year later, so she's very happy. The 59-year-old woman with paraplegia, the MRI showed an enhancing lesion T8 to T10, which was initially thought to be an intramedullary tumor. She was treated with high-dose steroids, but the paraplegia did not resolve. She wound up getting a laminectomy, and after they debrided this infarct, she improved substantially. So then in summary, modern devices and ICD systems can be MRI safe. Image distortion occurs around the generator and leads. Special precautions needed in performing MRI in patients with implanted devices. And the clinical implications are that using the safety protocol, patients with pacemaker and ICD systems can safely undergo diagnostic MRI and EP studies and ablations. And I'd like to thank all the investigators who participated in this project. Thank you very much for your attention.